Alright, welcome back. We'll be talking about chest pain today. So, introduction. Approximately 7 million patients within the US present with chest pain to the emergency department each year. Over 50% of these patients are admitted or placed in observation units, and only 10% are diagnosed with acute coronary syndrome. So, it is a very common presentation within the ED, and you always have to rule out life-threatening conditions first, such as acute coronary syndrome, pulmonary embolism, aortic dissection, and tension pneumothorax, and esophageal rupture. So we'll be talking about the definition of chest pain and how you can actually know whether this is a cardiac condition or a different condition. And then we'll also talk about the clinical approach within this lecture. So ischemic heart disease is a spectrum of conditions. It is caused by myocardial ischemia due to coronary artery disease, and it includes a spectrum from stable angina, so chronic coronary syndrome, and also unstable angina, non-ST elevation myocardial infarction, ST elevation myocardial infarction, variant angina, and silent ischemia. So typical chest pain it has three specific characteristics: that it has to be substernal, so behind the sternum, worse with exertion, and then better with rest or nitroglycerin. So this is what we call as classical chest pain. Now, the word typical or atypical is less used nowadays, and it's more of a classical and non-classical chest pain. Now, stable angina is actually caused by a fixed narrowing of the coronary arteries, and then there's this imbalance between the oxygen need and the supply, which then causes the symptoms. The symptoms are more predictable, and they're relieved by rest and nitroglycerin. And it is also known as chronic coronary syndrome. So this is a second or a synonym for stable angina. Now, how are you going to diagnose stable angina? And then, because the patient doesn't have any symptoms at rest, you want to do a stress test or a stress ECG. Now, the indications are a normal baseline ECG, and he has to be able to do exercise. The contraindications would be someone who has an abnormal baseline ECG, such as a left bundle branch block, pre-existing ST changes, and a left ventricular hypertrophy or a strain pattern. Exercise-induced ischemia causes subendocardial ischemia. That's why on the ECG you will find changes such as an ST segment depression. Now, in case someone cannot exercise, you want to do a pharmacological testing. And in this case, you give drugs like adenosine or dipyridamole, which causes vasodilation of all the coronary arteries as a whole. And because you have this slight narrowing of the diseased arteries, the generalized vasodilation actually takes away a little bit of this blood supply from these coronary arteries, causing a stress pattern, or it will cause ST depression in the areas affected. Now, diseased arteries receive less blood flow, as we said, and then you can find that on the ECG. Dobutamine is another drug that can also be used for pharmacological stress testing, and what it does is it increases the myocardial oxygen demand. And so what we do is we ramp up the heart, we perform an echocardiogram, and we look at the heart. We look for the ejection fraction, we look at the wall motion itself. Is there any hypokinesia or dyskinesia? We look at the pressures, the ventricle pressures, we look at the chamber sizes, we also look at the velocities of diffusion of blood across the valves, and maybe there is perhaps any valvular diseases. Now, the management of severe coronary artery disease in cases where the patient has stable angina, but it's so what do we mean by severe? If the affected artery is a left main coronary artery, or if there's 3 vessels affected, or the patient has 2 vessels affected with diabetes, then this would be regarded as a severe coronary artery disease. And in this case, you would actually perform surgery rather than performing a PCI or medical therapy. Now, the pharmacological treatment of stable angina. So in this case, you would like to, there's two categories of drugs that you want to give. And these are drugs that improve mortality and actually lower the risk of this patient of having cardiac complications, such as aspirin, high intensity or large dose statins, and then the new generation of lipid lowering agents, the PCSK9 inhibitors. Now, drugs that relieve the angina itself and causes vasodilation of the vessels, such as beta blockers, nitrates, calcium channel blockers, and ranolazine. Now, beta blockers, they actually lower mortality post myocardial infarction, but in cases of stable angina, they do not lower mortality, but rather just relieve the anginal symptoms. The side effects of beta blockers include erectile dysfunction and a blunted heart rate. So, of course, because you block the beta-1 receptor, so the sympathetic system lowers the heart rate. Nitrates, of course, they cause vasodilation and venodilation, causing lowering of the blood pressure. So that causes headaches, orthostatic hypotension, and even tolerance. So the nitrates, with time, they wither out and you need higher doses. Of course, they cause syncope as well. Now, in cases where we were to compare if the patient didn't have extensive disease and he has stable angina, we want to offer either PCI or medical therapy, because both of them were actually seen equal in their effect. So there's no significant difference in mortality. Okay, so maximum medical therapy alone is as beneficial as doing a PCI. Now, bear in mind that drug-eluting stents are superior to bare metal stents. So they were seen to be more superior and better in decreasing mortality. Now we're going to talk about the other different differential diagnosis of chest pain. So, as we said, one of the differentials could be a stable angina, an acute coronary syndrome, pericarditis, aortic dissection. That's if it was a cardiac cause. Could be also a pulmonary cause like PE, pneumothorax, pleuritis, pneumonia, status asthmaticus, and gastrointestinal. These ones can be quite difficult to differentiate from cardiac, such as GERD, esophageal spasm, which actually is relieved with use of nitroglycerin, peptic ulcer disease, and esophageal rupture. Now, with an esophageal rupture, you might see on an X-ray the pneumomediastinum, or you could see also crepitus, surgical emphysema within the neck. Now, chest wall problems could include costochondritis, muscle strain, rib fractures, and herpes zoster. Psychiatric panic attacks can cause also chest pain. Anxiety can cause chest pain, and somatization. Somatization is basically someone who has psychological issues presenting as physical symptoms without a known medical condition. So the patient can have psychological problems presenting as chest pain, and then he would come to the emergency department, or perhaps coming to a cardiologist, and the cardiologist would perform tests and he would see that there's nothing wrong with his heart. Now, also substance related like cocaine and methamphetamine can actually induce angina and myocardial infarctions. Now, the pathophysiology of chest pain. So how does it work? So whenever, of course, there is a decreased supply of a certain part of the heart, the visceral pain fibers actually sense this, and they send it to the spinal cord. And then these areas map to areas on the parietal cortex. So that's why you get the somatic symptoms. But these symptoms aren't as specific as somatic pain fibers. So you would actually feel symptoms of discomfort, heaviness, pressure, and tightness or aching. Whereas somatic pain is more localized and easily described. These symptoms also may radiate to the neck, jaw, and arms, which actually increases the likelihood that this could be an acute coronary syndrome. Pain perception and communication are influenced by age, sex, comorbid illnesses, medication, substance use, and psychological, cultural factors. So, not everyone experiences pain the same way. There may be societies who see pain as less than what they actually feel, but some others cannot withstand simple pain. So it's a very objective symptom to be talking about. Pain is very objective. Now, once someone comes to the ED and complains of chest pain, the first thing you want to do is look at the vitals and any abnormality in the vitals. This means you rapidly have to have a bed for this patient. You would start treatment. Now you want to perform an ECG. You want to ask if he's had previous cardiovascular events or if he's done any PCIs previously. And you want to ask about risk factors. Now, risk factors are important because patients with multiple risk factors make them more likely to have an acute coronary syndrome. However, if the patient presents with chest pain and does not have risk factors, that does not mean that they are less likely to be presenting with a myocardial infarction at the moment. No, you treat everyone with chest pain in the same fashion. That's the tricky part about cardiovascular diseases. Abrupt, new, or severe chest pain or dyspnea should trigger urgent assessment. So if there's any change with the symptoms. Now, a traditional teaching, or this is not very precise, but it's just to actually emphasize that anginal pain starts first. So this is a stable angina which can last from 2 to 10 minutes. And then once the closure of the artery progresses, it progresses into unstable angina. Now, of course, there wouldn't be ST elevation or depression or ST changes on the ECG, but later on, when there is myocardial damage, and that's after 30 minutes, that's when ST changes happen and troponin is released into the blood. Of course, you put the patient on cardiac monitoring, and you have to have IV access. So you want to insert a cannula, 2 large bore cannulas on either side, especially if the patient is unstable and his vitals are unstable. So you want to do an ECG within 10 minutes. That's the maximum amount of time for highest survival rates. You want to also perform an ABC, so assess support the airways, breathing, and circulation. You want to measure the vital signs and administer oxygen if the saturation is less than 94 or if the patient is in severe respiratory distress. Now, as we said, the chest pain can be outside of the chest itself, so it can be in the epigastrium. That's what makes difficult separating or differentiating GI diseases from cardiovascular symptoms. So anybody complaining with epigastric pain has multiple risk factors or previous PCI or MIs you want to do an ECG for. It could be neck pain, jaw pain, shoulders, or the arms as well. Some patient may not experience chest pain at all, and that's very common in, for example, diabetics, in women as well. Women are more likely to present with less classical symptoms. It could be migratory pain, so that the pain started in the chest and then at time of evaluation it moves somewhere else. Now, the pain descriptions, you have to look into these. So the type of pain, if it's more of a I feel like I'm gonna die, if it's that type of description, or if it's discomfort, heaviness, pressure, tightness, or aching, that's more likely to be an acute coronary syndrome. Now, the characteristics, as we said, classical pain is substernal, worse with exertion, and relieved by rest or nitroglycerin. The non-classic chest pain is actually pleuritic pain, so it worsens with breathing, or positional pain, which changes with posture, or reproducible pain elicited by palpation. So the non-classic chest pain, now these are less likely to be acute coronary syndrome, but they do not rule out an acute coronary syndrome. So if the patient has chest pain with pleuritic nature, or changes with position, or is actually tender on palpation, you actually want to still perform an ECG, because some patients were seen to have such features and still present with, and further down with investigations, were found to have acute coronary syndrome. So we'll be continuing the lecture. These were the references used for this lecture. Thank you for coming, and hope you have a nice day.